After this meeting, I'll email
Okay, she's Dr. Moran ready to introduce speakers.
Conference has begun, ma'am.
Okay, thank you.
Go ahead.
Good afternoon. Thank you, everybody, for being here. I have a question. Is there anyone who doesn't know who Mike Cohen is? Can I see hands? Okay. I was just standing here and looking at how many, what's the proportion of people he's hugging as they come through the door. And clearly he does not need an introduction. But I'm going to give one anyway, which will be very brief. So obviously we all know him for his work on transmission and prevention of HIV. But before that we knew him all about because of his work on gonorrhea. And he was a very famous infectious disease specialist when I met him, which was before HIV. And then you kind of figure out what he has become since then. So what he has become is the architect and principal investigator of the multinational HPTN 052 trial, which demonstrated that antiretroviral treatment of people with HIV infection prevents the sexual transmission of the virus. I'm sure you all saw that this work was recognized by Science magazine as the breakthrough of the year in the year 2011. Mike has received the Distinguished Career Award, previously known as the Parent Award, from the for lifetime achievement in STD HIV research from the American Sexually Transmitted Disease Association, the Smadel Award from the Infectious Disease Society. I just missed another hug, didn't I? The Smadel Award from the Infectious Disease Society of America, the Gardner Award from the University of North Carolina system, and the Award for Science from the state of North Carolina, which is apparently the highest honor in the state. He's a member of the American Society for Clinical Investigation, the American Association of Physicians, and the Institute of Medicine. He's a fellow of the American Society of Microbiology and the Infectious Disease Society of America. He's a very well-loved friend to lots of people in the STD HIV research field. And it's a great honor, Mike, and I thank you for having said yes to this invite.
Thanks. Thanks. Well, I'm going to use slides, as you might guess. And my point, so I have about 45, 50 minutes to talk to you. And I thought that this is a little bit difficult because I was trying to think of what to say, in the sense that, and especially in a webinar, because this is like a generational thing. Not everyone, so for Sevgi and I and a few others who've done this our entire careers, we take for granted that everyone knows everything that happened over 30 years. But I don't really think that's true, because some things might have gotten lost in translation. I also think there's a lot of fields involved. So what I'm going to do in the next little while is talk in three kind of segments in a way. I'm going to talk about the transmission of HIV, and I'm going to show you some articles that you might not have seen or thought about that are very current that inform how we're thinking about transmission. I'm going to talk about like oldies but goodies of like how we came to the conclusions we've come to about STDs in particular as they relate to HIV. Then I'm going to talk about interventions, and then I'll be done. So that's the plan, and I will use these slides. So the first issue is this. We understand that the transmission of HIV is a biological event, and by the way, this is true, of course, of any pathogen, but today we're focused on HIV and STDs, and the transmission has got to result from the infectiousness of the host, what's the concentration of the particle present, in this case HIV, and not all these particles are the same, and that's really quite important in our thinking of prevention. There are different types around the planet, and each virus has its own proclivity to have a probability of a transmission event. Susceptibility must depend on hereditary resistance, which in the case of HIV is constrained to CCR5 deletion, the one receptor on the cell surface. People have looked extensively for other genetic dispositions that would prevent HIV, and they've not been found. And as an aside, the way that was done was to take hemophiliacs from the original epidemic in the 80s, and to take all the hemophiliacs that never got HIV, and to take out the hemophiliacs who had a CCR5 deletion, and look at the remaining people with hemophilia, and look at thousands of people who never got HIV. And in that study, led by a guy named David Goldstein, no new abnormality was discovered to explain why they didn't get HIV. So it was an interesting study. Innate resistance is probably difficult to describe. People are very concerned about the microbiome, especially in women. This gets at the idea that the flora might be different and predisposed to acquisition or not acquisition. And acquired resistance would be somebody like in a discordant couple who, for whatever reason, can never get HIV. They've somehow acquired a magical resistance factor, and that's very, very rare. And why do I say that? Because when we study discordant couples, and the person who's not acquired HIV, they've only not acquired HIV till they acquire HIV, right? So you've enrolled discordant couples, and in the absence of interventions, about 10% per year will go on to acquire HIV. So this is how we think of this problem. Now, once the acquisition event has occurred, it's pretty straightforward. There's a window during which the virus is only living in the tissues, and that window is about 3 or 4 days, probably in most human beings. And after 3 or 4 days, the virus has grown to sufficient concentration in the tissue to escape the tissue and be in the bloodstream. And once it's in the bloodstream, it can be detected by PCR. Now, and the antibody formation, even with the very best tests available, is many days after we can detect the virus in the bloodstream. At the time when the acquisition event occurs, as I'm going to tell you in a second. By the way, can you understand me at this rate of speed? Okay, this is way too fast for North Carolina. Who's from North Carolina originally? And I don't want to insult anyone, especially you. I don't want to insult you, but you know, people with North Carolina will sound and say, that's too fast. You're talking too fast. And I'd be on my first slides. But because I do talk I'm from the Midwest, and I talk very, very fast, especially when I like the topic like this. So there's this transmission event that's occurred, and then it turns out that the infected person, the host, that had a viral concentration of the tens of thousands of copies of HIV, each of those copies, let's look at about semen for a second, each copy is different, because when the virus replicates, it lacks fidelity. And so it generates copy after copy, but no two copies are the same, or very rarely are two copies the same. But the acquisition event is going to be with 1 or 2 viruses. Okay, there's a sieving event. Something happened where not all the viruses could cause infection. 2 viruses cause infection. So now you've got what's called the ramp-up viremia, but the ramp-up viremia is with a virus that was selected to occur in that host, that was allowed to occur, and we know it's capable of going to the next person, right? So the highest concentration of virus you'll ever achieve is during ramp-up viremia, and many people would argue that the most infectious virus that you'll ever have is the virus you acquired from the person that you just acquired the virus from. Does that make sense? Now, 2 other bad things happen during this acquisition event. First of all, every compartment in the body is seeded. So the brain is seeded and the testes are seeded, and so if we're ever going to cure HIV, we can't just deal with the corpus. We have to deal with every compartment in the body. The other problem is that the virus incorporates in a particular way into the host genetic material so that it can achieve latency. And what does that mean? It means that when we offer treatment later, the treatment will stop the growth of all replicating viruses. But when we stop the treatment, the cells that were hiding and were latent will leave latency and regrow to the exact same concentration they were before we started the treatment. So the virus has a memory, and it knows what its set point was, and it achieves a very similar set point within reason when it regrows if we stop the treatment. Of course, the greatest breakthrough of the HIV era was the development of antiviral drugs from 87 on that stopped the replication of HIV. Now, this is an example of what happens is the donor blood, the donor genital tract, with all these different colorful viruses present, and then when the acquisition event occurs, the sieving has occurred so one virus has caused infection. Now, just to kind of be very totally current and sensitive to discovery at Emory, because Emory is in Atlanta, a very important paper was published by Carlson and Eric Hunter's group, in which they argue that they can understand some genetic changes that allow viruses to be more or less transmissible. And why is this important to our discussion? Because in the universe of their work, here's what they did. They had 137 transmission pairs, the infected person and the partner. They studied the virus transmitted from the infected person to the partner. They examined the amino acid sequences encoded by what are called non-envelope genes in the founder virus. The founder virus is the one virus that caused infection. They said that the transmission probability reflects a specific fitness dependent on the genes they were studying. But that fitness was not required at the same level in men who acquired HIV who had an STD. The fitness requirement was reduced, and the implication is that the STD reduced the fitness requirement. They didn't observe the same thing in women. So this to us is a very important example of the kind of selection biology that's going on to allow an acquisition event. Another really important paper is one that I participated in, and that is when you look at the founder virus again, it's got the founder viruses have increased or decreased susceptibility to interferon alpha. Interferon alpha is one of the cytokines you can detect in the female genital tract. And so the argument is that you're selecting a virus that is ready to go to the person because of its interferon resistance, if that makes sense. And at the end of the day, here's the basic problem. When we were studying this a long time ago, and we published a paper, first author Rachel Royce, in which we made an argument about how many episodes of intercourse it would take in order for an HIV transmission event to occur. But it turned out that the literature suggested like thousands of episodes of intercourse, like 1,000 episodes of intercourse. Like, don't raise your hand about your own experiences. But try to think if you really had 1,000 episodes of intercourse. Do you want to have 1,000 episodes of intercourse? I guess it depends on your relationship. But the point is most people, when they start adding it up, they say, wait, I'm only having sex 60 times a year or 80 times a year. That would take me 12. That's a number that's in the literature about it. I didn't make that up. There's a guy, Ed Lauman, who's very well known to us, who studies like sex in Chicago, sex in China, sex in Europe, and everybody has sex the same number of times except when they get older. But the point about this is that when we looked at this again more carefully, we realized that the number, the thousands of episodes of intercourse, was not right, and that there must be amplifying events. And on this slide, and we refer to this as amplified transmission of HIV, and you can amplify transmission in a couple ways. You can amplify it because infectiousness would be greater, but mostly that has to do with increased viral load. And you see on the slide, bold-faced is the person with acute infection, because they have the very highest viral load. So the idea that we see people clustered around a person with acute infection makes perfect sense. And we know that to be true among gay men clusters. Okay, we know within gay men populations that we'll see clusters with the same exact virus that we believe is occurring because of acute infection acting as a provocateur. For susceptibility, we're mostly focused on inflammation, and that gets us into all the STDs or lack of circumcision. So we'll talk about that in a little more detail right now. And that requires the oldies but goodies, okay? So some people will recognize these slides instantly, or this article. First, Judy Wasserheit, much beloved in this organization, was really one of the leaders in describing the synergy between the classical STDs that cause inflammation in the donor and in the recipient and HIV acquisition. And then subsequently, and Judy's paper and then a lot of other studies, this is after that paper, these are just a few of the many, many studies that look at the odds ratios in a cross-sectional study of the presence or absence of an STD. You see chlamydia, gonorrhea, and trichomonas, and you see really a high, you look at the bar at the bottom is the odds ratios up to 30, and you see when you're identifying somebody who's acquired HIV, the probability that you're also going to find gonorrhea in the background was very great. Likewise with chlamydia, likewise with trichomoniasis, and very much likewise with herpes, which I didn't show a slide, because there are 25 papers looking at herpes and the acquisition of HIV. And all of this gets the idea that was true and remains true, that the attributable risk of the acquisition of HIV is hugely dependent on the presence of an STD. and I don't think any of that's changed. And if we look at the genital ulcers, you see the scale has changed to 80, and you see these huge odds ratios of acquiring HIV in the presence of a pathogen capable of causing a genital ulcer. And again, none of our thinking has changed about these attributable risks and synergistic amplified parameters. We did a study that attracted attention in the 90s and one of the first intervention studies. So, and this led to a series of intervention studies. And this study was from Malawi, published in The Lancet. We started in about 93 or 94. And what we were trying to do was understand if we took a person with HIV and gonorrhea, how much HIV was there in their semen, and if we gave them antibiotics, what happened to the HIV in their semen and how long did it take? And what we showed was that in the control group, there's a small concentration of HIV in semen, and when we looked at patients with urethritis or specifically gonorrhea, we found a lot more HIV. And then when we, I'm sorry, let me go back. It might be possible. Well, allow me to tell you what is on that slide, since I'm incapable of going backwards, back in rear. So then when we treated gonorrhea, that we saw a very rapid fall in the concentration of HIV in genital secretions. And then we did a similar study in Trichomonas, where we treated Trichomonas, and we showed that the HIV concentration was greater in women with Trichomonas. We treated Trichomonas, it went down. And there were many, many studies subsequently like this of before and after treatment, demonstrating that treating the classical STDs could play a positive role. Now, it kind of brings us then, and none of this has changed. This is all just as true as it was then, now as it is then. So then what we've seen in the more modern era are a series of studies trying to dissect the biology further. So Joanne Passmore, she's one of several investigators who works in this area, but she's trying to understand specific inflammation and the risk of HIV acquisition. And what's important on this slide is, like, this is a Kaplan-Meier curve of acquiring HIV in a study that he called CAPRISA 002. And you see in the absence of an STD, your risk was fairly modest. But if they found one STD here, you start falling off the curve and acquiring HIV. And if you have more than one STD, visits where an STD is present, your chances increasing. So this is, again, consistent with our notion that STDs, classic STDs, are driving HIV. Then what Joanne has done, and other investigators as well, but I'm focusing on her work, and she lent me these slides, she looked at 32 cytokines, and she divides them into inflammatory, regulatory, growth factors, and adaptive, but we're concerned about inflammatory cytokines. And then what she subsequently has done, and most of this is not published, so if you search her name, some of it's published, a lot of it's not published. If you search her name, you'll see that she's tried to dissect which cytokines, and they're shown on the right-hand side here, IL-1 beta, IL-6, IL-8, she finds to be more likely to contribute to the acquisition of HIV. And she continues to work on this area, trying to get ever more narrow of what's forcing the acquisition of HIV. Now, why is she doing this? Because the idea is another way to interfere with HIV acquisition is to develop inhibitors that block these cytokines in the female genital tract, or to be sensitive to risk groups that are more likely to have these cytokines in the female genital tract. And this is an example of how you can do this in CAPRISA 04 is another one of their studies in Durban, South Africa, where they're looking again at susceptibility. Now this is a heat map of genes, and she's showing the green are genes, or the red are genes expressed, the genes not expressed. And in the presence of STDs, these genes get expressed, because it's going to force inflammation. And then we look at kind of this risk curve of the cytokines, HIV positive, negative, genital inflammation present or absent. There's an odds ratio or a p-value that suggests that if you have genital inflammation, the most common cause of genital inflammation are untreated STDs, you then are more likely to acquire HIV infection. Now, I'm going to slow down on this next thing, because this is like something that no one's ever seen. This has not been published anywhere. So this guy, Abraham Olivier, works with Clive Gray, and he lent me these slides from a presentation just a couple of months ago. And their argument's a little bit different, but I think it's a really important argument for this group. Their argument is that STDs, classical STDs in the male, like gonorrhea and chlamydia, force changes in foreskin that contribute to the acquisition of HIV. So that's important for a couple of reasons. It drives the STD question forward in the male in a different way, because we mostly focused on the urethra or the rectum, Now they're focusing on the foreskin, and it makes you rethink a little bit about how does circumcision work. Is circumcision working by removing the foreskin, which is the risk factor, or is it working by reducing the overall incidence of STDs in these male subjects? So what did they do? How they're getting the foreskins, I'm not going to tell you, but now they're getting, so this is not my study. This is these guys' studies, and I thank them for allowing me to show their work, which I think is really important. Clive Gray, as I said, is the leader of the group. They're getting these foreskins, and they're looking at STD positive and STD negative. And it's pretty obvious in looking at Langerhans cells, which are cells to which HIV can bind and then be handed to a CD4 positive cell. And so look at the difference in these Langerhans cells in the foreskin. There's inner and outer foreskin, and they see a really big difference in the face of STDs, and they see this odds ratio of the cell density being way, way higher, many more cells that would contribute to the acquisition of HIV. And then they look at CD4 cells, and we see the same kind of thing. The pink is a CD4 cell here in their staining. Ki-67 is a molecule associated with inflammation. No inflammation, a lot more inflammation. Fewer CD4 cells, a lot more CD4 cells. HIV is looking for a CD4 cell that is expressing on its surface both CD4 and CCR5 ligand receptors. And then they look at the same kind of thing. They look at the outer foreskin and the inner foreskin, and they look at the number of cells in the presence of STDs and the absence of STDs. They find this big difference. I find this work intriguing for this kind of overlap between HIV and STDs, and I would congratulate them on their work. So what do STDs do? They reduce the physical and mechanical barriers unequivocally, like a hole in the mucosa is visible. It's not rocket science. They increase the HIV in genital lesions, semen, cervical cells and fluid, and vaginal secretions. They might evoke a more infectious variant. We did work on this a few years ago. What variants are present in the face of inflammation? Possible that there could be a higher concentration of variants that want to go to the next person. They also could induce a swarm that's more diverse, or they could, as has been shown by Carlson, reduce the fitness requirement. And that's really important. So that reduced fitness requirement might really inform our thinking as we go forward. They certainly increase the number of receptors per cell and the density of cells, and I've shown you a slide, one slide ago, that shows you that fact. And they can increase the recurrence, this is now STDs, can increase the recurrence of other STDs, like the increased recurrence of HSV and severity of some STDs might reduce the benefit of treatment so that the treatment is less efficient. And we saw this mostly in Malawi with chancroid, where chancroid was very difficult to treat, even with the appropriate antibiotics, so therefore the time of risk of acquisition of HIV would be extended. So this is like all by way of like the first 20 minutes of what I'm going to say. But now I'm going to take a breath, since it's been anaerobic up to this point. Because I thought, okay, this is just by way of background. So now I've really got to get into what does this all mean. Okay. So this, to my knowledge, is everything we know how to do on this planet to prevent HIV. And, of course, in the unexposed or uninfected person, we are striving to have important behavior change. We see increasing success and potential really important success in structural intervention, especially in girls in sub-Saharan Africa. And there's some big studies coming to conclusion this year about management contingency and cash incentives and school uniforms and things of that nature, which we're very excited about. And I think no one would doubt the value of condoms as they're used properly. The value of circumcision, I think, has been very well established. And then STD treatment. And it's the STD treatment part that I think has, I wouldn't say it's run into trouble, it's just lost its shininess, right? And my goal is to make it shiny again, to make it spark glitter. I have a granddaughter who loves glitter, so everything that's mailed has glitter on it, you know, like it's glitter all over her house, and you walk in and you're covered with glitter. I think the STDs need more glitter. Now, and I'm going to try and re-deliver the glitter to STDs. So if that's what we've been doing, and when people get frustrated and say, well, this didn't work, well, I would argue that no one knows what the epidemic would have looked like had we not done all the things for 30 years we did. There might be 60 or 70 million people with HIV infection instead of 30 or 40 million. The middle part of this is the most difficult part. It would be carrying coals to Newcastle to talk about PrEP and PEP here, but those are obviously things that are in development that one would hope would realize their full potential over the course of a generation. And certainly for PrEP, there's a lot of movement in changing the way it's delivered and also in newer products. So there's enough energy in new product development that's important. And that includes the microbicides, of course, where this year we'll hear about the rings, the defibrillin rings that have been so long in development, whether they work or don't work, which would be exciting. But I think, we have Truvada PrEP. We know it works. We know that people who take it, it works. And so it opens up a whole door. But the PrEP and then vaccines are heavily sought after, and there's no lack of enthusiasm to make a vaccine. And earlier this morning we talked about the vaccine field. I'm not going to talk about it now. There's a lot going on in the vaccine field. But these are kind of bookends. The other side of the bookend is the infected person. And for the infected person, we have two options. Treat the HIV and hope to reduce the transmission by reducing infectiousness, and treat STDs with the belief that some percentage of people who might shed HIV in the face of an STD, even in the face of ART, may represent a risk to the partner. Although that is a thing we've never sufficiently proven. So these are kind of bookends. This is one side of the bookend, this is the other bookend. I'm going to talk about the first bookend first, because it's this side, because it's narcissistic. I must talk about myself. So HPTN 052. So in the 80s, we started doing HIV prevention research. In 87 and 88, AZT was developed. And even from the very beginning, as soon as AZT was developed, we had this idea that the drug could work in one of several ways to reduce the transmission of HIV. So a large group of people at UNC and elsewhere all worked on this idea. We started working on HPTN 052 in 1999. We developed, approval for development was set off. We got drug procurement potential from 6 drug companies in 2002 to 2005. We couldn't start this trial without 6 companies donating their drugs. And in the case of Glaxo, we consumed a huge amount of their philanthropic supply of drug. We did a pilot in 2005. The purpose of the pilot of this study, 052, was to understand whether the drug worked the way we thought it would, and whether people would take the pills the way we thought they'd take the pills. That 2-year pilot was really important. So those who do clinical investigation, I would strongly suggest you think about piloting big studies for a substantial period of time before you go forward. We started the study in 2007, and we achieved full enrollment by 2010, and then we had a fateful meeting with our DSMB in 2011, actually. I never fixed this slide. It's interesting. It's April 28, 2011. This study was conducted, enrolled 1,763 discordant couples, one person positive, the other negative, in 13 sites in 9 countries, oversampling Africa because it's the epicenter of the epidemic. And the study was very straightforward. But important to say, even at this moment in time, the study's not over. This is an ongoing study. That's kind of unknown to most people. We divided people into, they were randomized to one of 2 groups. Immediate ART with CD4 count of 350 to 550, or delayed ART with CD4 count greater than 200 but less than 250. Now, obviously, the ethics of all these CD4 counts have changed over many, many years. But this is how it was when it was in its heyday. And there were 2 endpoints to the study. One endpoint was, did we see a transmission event? But a transmission event wasn't sufficient. It had to be a virologically linked transmission event. That required us to develop some new tools led by Sue Eshelman to better understand how we could make absolutely sure that these viruses were linked. So one endpoint was a virally linked transmission event. The other endpoint was clinical. Did people improve if they got ART sooner in their course of treatment? Nowadays, that's considered a trivial issue. When we started the study, it was a really big deal. And the reason the study was held up for many years was people said, everyone knows you can't start people before their CD4 count falls below 200. So the world will change dramatically during the course of a research study. Of course, every one of these people received, we spent a whole year with our health behavior group at UNC developing a script to maximize counseling. Because before this, the estimation was 8% of couples would transmit per year, 8 to 11%. We wanted it to be at least half that. And the power calculations were that the counseling should reduce transmission to less than half. So we had free condoms and counseling about monogamy and don't have sex, don't have sex, don't have sex. And if you have sex, use a condom 100% of the time, and so on and so forth. Now, of course, we were working against ourselves because the fewer transmission events, then the less likely the study would ever complete itself. So very early, we were very afraid that we'd never finish the study because we were such good counselors. Because 100% of the time, The partners said, we're using condoms every single episode of intercourse. We never fail, like never. But like 200 times the women were pregnant. And so the woman would say, we use condoms 100% of the time, but yet they were pregnant. And that we weren't, it wasn't confrontational. It was like, okay, people don't always, there's a social desirability, and people, don't always tell you the exact truth in these visits. So in the end of the day, we fully enrolled this study, and to our great joy as I go forward, the actual control group here, HIV acquisition in the control group was less than 2%. So actually, the counseling alone was a powerful intervention to reduce HIV acquisition. But the study had been powered so it would still be able to see a result even if the HIV acquisition in the control group went below 4%, which is what we were thinking it was going to be. So we were doing the study, and we were minding our own business, and everything was going great. And the way it works is you have no results. Now, this is a problem because we had been working on this for 11 years with no abstracts, no reports, no papers, nothing. So that is not the way to start your career. If you're like a young person in this audience, do not think of doing this. This is not a great idea in terms of career development for somebody. But, we were kind of going to do it, and we were doing it. And the only people who had any results were the Data Safety Monitoring Board, who we got to know very well because we met with them every 6 months. So in our 11th meeting, or 10th or 11th meeting with them, and when you go in, it's a very anxious moment in time if you haven't done this because, and we would do it a particular way. We'd have like a carbohydrate loading beforehand. You think I'm kidding? I'm not. We had a ritual. Humans are very ritualistic, and I'm subjected to that. Anybody here from Washington? Anybody ever lived in Washington, D.C.? Okay, well, we went to Tasty Diner, okay? At Tasty Diner, we'd have like the same breakfast every time of pancakes, eggs, bacon, potatoes, coffee, and we'd eat this huge breakfast and be kind of sick. Then we'd go to this meeting. I'm not kidding about this. We'd go to this meeting, and then you go in, you tell them what happened in the field. So you're saying, here's what I think is important for you to know. They have all the data. Then you leave and wait for 3 tenths hours, fearing that they're going to say your study's futile. That's the words you don't want to hear, that you haven't enrolled enough people, that no one's getting an infection, whatever. Futility is a really bad word. And then they come out, or they bring you back in, and they say, well, we have some recommendations, and we have no recommendations. So on this day, our 10th meeting, we went in, and so I went, and here's this picture of these guys. You'll see how my artwork is like very effective. So we went in, and we said, okay, do you have any recommendations? So we were waiting outside, and they said, come back in the room, which is a little bit unusual, because they didn't always bring us back in the room, because we're in a line of people with the same board. I sat down, and they said, don't sit down. And I said, okay. And they said, we have a recommendation. And I said, okay, what's the recommendation? And they said, we can't tell you the recommendation. So I said, I thought that was pretty ominous. So I said, well, you can't tell me. How will I know what you recommend? They said, the NIH will tell you what the recommendation is at the appropriate point in time. So this did not go over well with my colleagues. So we were all together, and one of the people who I won't name by name, but some of you know, had worked with me on this forever, a wonderful investigator, and a woman, and who devoted really a lot of her time to the study. And so she said to me, I won't say the exact words, but I wasted my youth on this study. I can't believe, like, I'm old now, And this went on, and we're in an elevator, and I was giving a pep talk. It's okay, what it is. And I was supposed to get a ride to the airport, but I only got a ride as far as the metro, because people were screaming and yelling too much about, like, what had happened. So at the metro stop, the NIH called and said, can you come back to the NIH? And so I said, yeah, we'll come right now. We went to the NIH. So the NIH, they said the oversight board recommended the results of the trial be made public. They didn't recommend the trial be stopped. They didn't recommend any changes. They wanted us to make the results public. So what results did they want to make public? So what they had seen was we had demonstrated, and my colleagues had demonstrated, because I was a cheerleader more than a person, that 39 transmission events had occurred, 11 unlinked, 28 linked. And among the links, there was only, in the delayed arm or the deferred arm, there were 27 transmissions. The index cases not being treated, a transmission event occurred. Only one transmission event occurred in the group receiving ART, which was a 96.4% prevention. And subsequently, we showed that this person almost certainly transmitted HIV on the day they entered the study. And the way we could show that was because we can study the virus. And we can see the mutations from the founder virus, from the index case to the founder, and show the number of mutations which can only occur at a certain rate. That's published in PLOS about a year ago. So this was basically, at that moment in time, just about 100% effective. Now, this isn't over, so this is by way of Shakespearean forewarning. So we've continued the study, but the way the study's continued is we asked every person to start taking ART. But so immediately after the study, we made free ART available to all the index cases. And over time, we got virtually every index case on ART, but the study was always powered to let us look at durability. So it's magnitude and durability. So now, this summer on July 19th, I think it was the 22nd, we'll report 2 different abstracts. One will be the I hope, this is everything going well. The study ends May 2nd. One abstract will be entitled, since I've already written the abstract, this ought to occur, at least I've written what should be in the abstract. One will be called The Durability of ART Prevention in Sexual Transmission of HIV into Supporting Couples, the final results of the HPTN-05 study. And the other abstract, I hope, will be Examination of Linked Transmission Events in Supporting Couples, final results of the HPTN-05 study. So, obviously, I'm not going to tell you the results now, lest I be fired or something terrible happen. But this summer, we hope to reveal the results of the entire study, which are still blinded to me in many ways, although every person was invited to take ART. So it's blinded to me. I don't know, who got what or whatever, but I know that we're going to know the answers this summer, and I know that these are the appropriate questions that we'll try and address. So, lest anybody think I know exactly the answer in my head, I don't, but I know the general themes. So, on July 20th, please call me if you want to know what happened. Now, as was pointed out, this became the science breakthrough of the year. Bruce Albert said that results of galvanized efforts to end the world's AIDS epidemic, blah, blah, blah. The most important thing is that his mouth moved. And I don't know if I can go, oops. The most important thing when we get to Bruce Albert is I want my most expensive slide ever that I'm really proud of. I'm going to go really slowly. Okay, get ready. And watch his mouth. It moves. So this whole, even if nothing else was beneficial in this talk, you saw the animation by a woman named Emily Pike did that animation. All right. This was declared at least part of the end of AIDS, and obviously we thought this was hyperbole because there are some really big barriers to all this. When to start therapy is still debated. Acute HIV infection is a big problem. We don't find those people to treat them. The logistics and infrastructure necessary to treat your way out of the epidemic are huge, and the cascade, which everyone talks about, is an omnipresent force compromising the ability to do what we would like to do, to give everybody on the planet treatment. It's a great aspiration, but one has to be realistic. That brings us back to the other bookend. So I talked about this bookend because it's like a bookend I've worked on so long. This is another bookend that we've also worked on that we're committed to. So what about population-based interventions treating STDs to get rid of HIV? So there's a lot done with this, and I would strongly recommend those who haven't had a chance to read it, this Cochrane collaboration article, the article by Judy Wasserheit about all the trials that have ever been undertaken to intervene, including all the STD trials, a wonderful article, and then the kind of debate article of what happened in Mackay versus Tanzania, or Grosskreutz versus Hayes, about why did the population studies end up the way they ended up? Because in the end of the day, if we go back again in time, what we were trying to do is to demonstrate that we could treat our way out of the epidemic by treating STDs and not just HIV. And so here's all the trials, and you see what happened was the big home run was Heiner Grosskreutz in Tanzania that saw this really big benefit by treating STDs. And the other trials undertaken to recapitulate this result did not do so, which was a big blow to the field. And then Connie Kellum did 2 acyclovir studies trying to intervene with what was considered a huge attributable risk, that is HSV2, and neither of these studies worked. Now, I'm going to slow down just to say this. I do not believe that the studies that show STDs are important are wrong. Okay? I believe those to be 100% correct. The problem lies in the intervention. And the problem with the interventions isn't either what the intervention is. Like, for example, we're pretty sure now that the acyclovir used in the concentration used and the way used was not really sufficient to deliver the results desired. And in these other studies, you get a lot at who did you treat and when did you treat them and how did you treat them and so on and so forth. So if you go to that article by Hayes, what you would see is the argument about Uganda, Rakai versus Mwanza. Why was Mwanza, Tanzania, why was Uganda not a home run? Well, there's a lot of arguments here that may or may not be entirely correct. Sevgi pointed out this morning from the meeting she just went to another issue. You mind if I mention that? Okay. So there's a paper by a woman named Kate Grabowski in PLOS Medicine that looks at Rakai concurrently now and makes the argument that in Rakai, there's a lot of people coming into the community from outside the community constantly. The way she did this was study phylogenetics of HIV. And she was trying to understand, was the population closed? Did everybody have HIV in a way that would be understandable? Did one person transmit to another? What she demonstrated was some very large percentage of strains of HIV in the community were coming from other communities. This lends itself to the argument that when they were doing this population-based study, even if they treated STDs effectively in the people there, they couldn't control for the people visiting there. And that further compromises the intervention. Have I reiterated what we were talking about? Okay. So in summary, interventions can only work if you treat just the right people at just the right time with just the right drugs. And a cyclovir standard dose is probably not the right drug because it probably isn't sufficient to reduce inflammation that's associated with HIV. Now, 052 worked for a reason. It's because we had couples. They're constrained, right, to agree. We would know they got HIV from somebody else. And we were monitoring viral suppression. So we knew the people did not have viremia. If we had done this in a way where we didn't know who had viremia and did not have viremia, that study would have been a mess. Is that pretty clear? In other words, we knew if somebody grew virus in their blood, we could go to them and say, this is not good, you need to take your pills, or we need to change your prescription, or whatever. But had we done the study blinded about the viremia part, it would have been a big mess. So enough about that. So what do we do about STDs now? Okay, what can we say now in 2014 going on 15? Well, first of all, they need more glitter because nothing's changed, okay? It's not like they're not just as important now as they were then. They're just as important for HIV, and they're just as important to the public health crisis in this country and other countries. Nothing different. And I think we can say, we can get into kind of 4 topics that are worth thinking about. First, HIV-infected people get STDs. You know, they don't join a monastery. You know, they're going to live their lives, and they're going to get STDs. And kind of by virtue of population dynamics, they probably have a higher prevalence of STDs than some other populations. Once they become HIV-infected, their risk behaviors don't just disappear. The second, circumcision might have a role in the STD field. Third, partner notification. It's never really realized its potential, either in the STD field or the HIV field. And lastly, most importantly, there's the misunderstanding by people who are very well educated about HIV spread about what STDs do and don't do. The loss of glitter is more than just the loss of glitter. It compromised people's interest in this in a way that, well, who cares about this? Well, people need to continue to care about this. So HIV patients acquire STDs. Seth Kellichman did a wonderful review of 37 studies of co-infection after diagnosis. The point prevalent was about 20%, and STD reinfection was often soon after diagnosis. So I'm just going to show you an incredibly complicated slide. He made the slide. I didn't make the slide. But nevertheless, it's a really informative slide. You look at the bottom, it's all these different STDs, and then if you look at he gives you the kind of location, and then he's got the number of people who get this infection, and then he's got, like, in these different colors, like the percent getting infection. Now, what I want to really focus on here, especially with this group, is syphilis. So clearly, something's gone wrong with syphilis in the United States and probably on a worldwide basis. So in North Carolina, where I have permission to give the number I'm about to give specifically, that we had like about 400 to 500 cases last year and about 800 to 900 cases of syphilis this year. And I'm told that at least a substantial percentage of the 900 people are HIV-infected people. So our syphilis detection in North Carolina, as one state, is going way, way up. And I don't know if it's been, I shocked Dawn, that scares me. You're shocked. This is a number I was told yesterday by a reliable source. But my veracity often is missing. But here I got it exactly right. She told me and sent me a slide. But I didn't use it. So anyhow, the bottom line is I don't think there's any argument syphilis is a problem in the United States. You know, it's a growing problem. It's not uncommon among people who are HIV infected. And it's with all we've said, it can't help but contribute to the onward spread of HIV. Now, many, many studies have been done in men and women of the shedding of HIV in the presence of an STD despite ART. So this is really important. Don't bother reading all the detail on this slide. This is old studies that Susan Kuyuvin's done, and I was going to throw these slides in, but Susan Kuyuvin's done newer studies, and our group has done newer studies. The point is, just because you're taking ART, you cannot count on no shedding of HIV. It occurs. And in the presence of an STD, shedding can be expected. shedding would be expected, a higher rate. Now, here's the thing we don't know. When the HIV is shed in the presence of ART, has it been compromised, or is it ready to go to the next person? The other point is if the ART is being taken at all, even in the shedding, and it's present, it may compromise the transmission event, right? Because the semen might contain ART and HIV, or the female genital secretions during the moments of sex. I don't know, there's got to be a medical word here. During exposure, during the moment of exposure, I know there's a right way of doing this, but not too sensitive. During the moment of exposure, the female genital secretions would also have ART if the person is taking ART. So the shedding may or may not be a big deal in the spread of HIV, but in general, it's something we ought to better understand and try and reduce, right? And one way to reduce it is to make sure we routinely detect STDs in people with HIV and treat them effectively. Because independent of HIV, it's not a good idea to have this untreated STD because it compromises many other areas of health. So this is how we think this looks. Acute infection, very high concentration, usually 10 to the 6th, more than 10 to the 5th. Suppression with ART, or elite control, but ART, and then breakthrough viremia in the face of inflammation in spite of ART. And it's possible that the odds ratios will go up during these untreated STDs. Another idea that we've already touched on a little bit is circumcision. Tom Quinn did a very nice review with some slides that I find compelling, and that is the effects of circumcision on acquisition, and he summarized in the Annual Review of Medicine from these different studies in different places, pretty big reduction in expected STDs, classical STDs, in the face of circumcision, which I find compelling and understandable in some ways. And then he argues as well that the probability of the circumcision also will prevent, obviously, STD transmission to the sexual partner. So now he's looking at a female partner of a male who's circumcised and arguing that the acquisition of an STD is reduced because the male partner was circumcised. So I think we may have underestimated the potential importance of circumcision to the classical STDs above and beyond their contribution to HIV. The third topic, and the last one I'll talk about, at least time for questions, is about partner notification. I mean, everyone in this room is familiar with the idea that you have to tell the partner that there's a problem, that they may have an untreated infection, and there'll be a rebound infection or ping-pong infection in the index space if you don't treat the partner, and that partner may put other people at risk. But we just have not done a great job at partner notification. So in this review, in the Cochrane review, they summarized 26 trials covering about 18,000 people as divided among men and women. And they say, and I'll just read it exactly, when combining trials of STI causing urethritis and cervicitis, expedited partner therapy, and they're focusing particularly on that, was more successful in simple patient referral for preventing reinfection, but was not superior to enhanced patient referral. So the enhanced patient referral is what we've traditionally done, and the weighing we're doing is expedited partner, give some drugs and try and get the partner involved versus do the traditional thing. But the bottom line is expedited partner therapy and intervention should include all components that were part of the trial intervention package and so on and so forth. But the point is, we can't go wrong trying to rethink everything we can do to work with partners of people with both HIV and STDs. We've not exhausted that opportunity, in my opinion. So here's the last slide I'll show, and then I'll leave time for questions. So to me, it's HIV prevention must include STDs. First, unequivocally, HIV will be detected in people with STDs. It's 1 in 5 in Seth Kalishman's study. There's no one I know who's ever studied this who doesn't detect STDs in people who are already diagnosed with HIV, especially right around the time of diagnosis. STDs are, so HIV will be detected in people with STDs, so that's the flip of what I was saying, the second line of it. So let me go back ever so slightly. The first thing is that if you have an STD clinic and you test for HIV, you will find HIV in excess in people with STDs, both because of the attributable risk and because of behavioral risk and so on and so forth. I've already said, and I'll say it again, that STDs are inevitably going to be detected in people with HIV. These two things are immutably connected. The treatment of STDs and HIV will reduce HIV transmission in the appropriate setting. So what does that mean? If you give ART to an index state, they're much less likely to infect the next person. If you treat STDs, you unequivocally will reduce the probability of a transmission event. You don't need a lot of glitter to come to believe that in a population-based trial. So, and then STDs need treatment regardless of HIV. This idea that we're all dependent on the HIV pandemic to justify the public health intervention makes no sense. So I summarize by saying, what would the HIV pandemic look like in the absence of all the energy we put into treating STDs and the other interventions you've undertaken, but especially STDs? And who in their right mind would forego the benefits of STD control, and why would you forego those? On that note, I will stop. Thank you for listening. Thank you. This is a particularly audience that knows everything about everything, so anyone may say anything they like. Free talk, as we say. Comments or questions? Gabriella? Okay. You're going to use the microphone because of the webinar.
That was a great talk. Oh, thank you for that. But I think that you're going to have to do a lot of talking and convincing to actually change the way that things are happening now. Because, I mean, research is so important because it informs public health action. And I think that the way that the funding is being allocated has already had things decided in terms of what can be done in terms of HIV money being used for STD control and treatment. So what's the plan?
Well, is that a question or a comment? No, I think it's interesting because we have an advisory board for the NIH network, and one of the comments was, are you paying enough attention to STDs in the research we're doing? Are we contributing enough forward-thinking information? I think the plan is, again, there's no one who's in the prevention field. There's no research study that I've seen designed that goes forward where people haven't said, what are you doing about the STDs in the background, okay? So that's considered so de facto that the researchers have incorporated that, right? So you wouldn't be able to write the protocol and write the trial and say, oh, yeah, I'm going to do this giant trial of a vaccine or whatever, and say, but I don't really care if they have STDs. You understand that would not be acceptable, considered unethical. The problem is going back to the public health community and saying, we've accepted this in the research community. Somehow the public health community or the public health funders have kind of lost their way about the importance of this as background de facto requirements. So you're asking me, how do we get more resources towards this end? My kind of feeling is that there'll be a convergence, and here's the convergence I see. So we saw the population trials in Mwanza and Rakai and such, and they go this way. And now we see all the giant population trials of ART treatment that are going this way, right? Community-based, community randomized trials. In the end of the day, the community randomized trials are going to make a great contribution, but they're not going to stop the pandemic. And in the end of the day, the STD population trials shouldn't have killed the field so badly, right? So I think it'll all converge with, and I'll say it in a way that would be acceptable to the NIH, combination integrated prevention, right? So our network that I help to run is devoted to combination integrated prevention. What does that mean? We don't just do PrEP or we don't just do ART communicase. Every trial includes all the components and including and especially the treatment of STDs. Now, the real question that I should ask you is, well, what research should we be doing? Since we're collaborators over many years, what research should we be doing that would contribute to this? The 052 trial was never popular. Oh, sure, it's popular now, but when it was, now today it's probably gone, my friend will tell you. This was not like, oh, what a great idea. There were two groups of people. One group said, you'll never finish this study, and it's stupid, and the other group is, it's not worth doing, and it's stupid. So there was no third group. There was no third group, okay? So it's like I'd like to say, oh, yeah, these people told me I should be doing this, but they didn't. So my question is, the STD field needs this kind of a similar intervention, if you will. We need to do studies that identify in a way that's very compelling the importance of diseases. Unfortunately, some of the trials we did, which were very well intentioned and very well done, they didn't work out, but not because the problem's not important, as I've said 20 times. You know, I mean, I think if the acyclovir people could go back, they wouldn't have used acyclovir in that context. You're an acyclovir person, by the way, because of your thesis, as I recall. If we could go back, we would have done them differently, right? You agree? And so I think we need to rethink what we do. Kim, you might want to comment on all this. You're writing the guidelines. They're going to come out next week, whenever. Okay. You have to go to the microphone. Kimberly might want to comment.
Well, one of the things that I think gets missed, and one of the things that you touched on, but I really haven't had anybody have any investment in, is TRIC. And you did some elegant studies back on TRIC. Mm-hmm. And nobody, and you know, it's like the neglected infection. Nobody cares about it except a couple of people at your institution.
It's orphaned. It's been orphaned.
And the issue is, what are we doing in terms of trick? You know, the ideas that I think have gotten into the trial in terms of, as you mentioned, doing the HSV and the syphilis, you're all doing that. We're getting some pushback from HIV folks about why we're doing extragenital screening. What's the use? We don't have any reproductive outcomes. So again, it's trying to inform people, like you're saying, that these are related. That's one point. So we're getting pushback from that. The other thing is, what are we doing on trick? And is trick really important? Thinking about what you did a really important study, but nobody's taken that to the next level with trick.
Well, thank you. First of all, thank you for saying something nice. I really appreciate that. And I think that, again, it's funny because focus. It's like there's too many STDs. And so what happens is you become a champion of syphilis or a champion of trichomonas or a champion of gonorrhea at the expense of the big picture. So I do think in the trials we're doing now, Kimberly, that we don't ignore the presence of trichomonas. And as the diagnostics have gotten better, it is another thing that needs to be focused on. But the question I really have to you and Gabi and others is, like, what do we do that's the most compelling thing to do? See, it's the compellingness that we need. There's so many trials that are worth doing, but we need like an 052 in the STD field, that is absolutely compelling, that kind of acts as a catalyst to get people rethinking this. Sevi?
So 2 thank yous. 1, thank you for a fantastic talk. 2, thank you for not asking, what are you people in CDC doing about the STD-HIV interaction? I really appreciate your not asking that question. And after Taraz asked his question or comment, we need to ask and see whether there are any questions on the phone.
Okay. Taraz?
In terms of using PrEP, one of the thoughts is that it's best targeted at people who have STDs. But are all STDs equal? And should we be perhaps targeting PrEP at folks with certain types of STDs and maybe not so much others?
Yeah, my own opinion would be yes, to be perfectly honest. I think the targeting is really critical. Again, this gets at this kind of home run thing. Sally Blower just published a paper that I find intriguing in Nature Communications, and she's arguing you want to get the most out of ART, as an example. You've got to go to these few hotspots. If you just go to the few hotspots and stop messing with the entire population, you'll do better. I think syphilis in New York City, I know one of you who may be in this room did a fantastic job in New York City demonstrating, and I'm going to cite this a little bit wrong, so I apologize, that the probability of an HIV acquisition event in a gay man with syphilis in the next 12 months was X. And X was who did that study? Say it again. Dr. Patella. Okay. Okay, and it's a she, right? And she demonstrated this very high risk in this very special population. And at the meeting I was at with her, I was like the moderator. It was like, okay, well, isn't this the exact right group to receive Truvada, which is already available, immediately? Now, I don't know what's happened with that, but that made perfect sense to me. So I would embrace your idea that, go bang for buck to demonstrate how you can get something out of the product. Very dynamic out of the product. I would agree.
Hello, operator?
Would you like to open it up for questions at this time?
Yes, thank you.
And on the audio portion, to ask a question, please press *1 on your touch-tone phone. You will be prompted to record your name, and please unmute your phone and record your name clearly when prompted. One moment, please, for the first question.
Do people always ask questions? Like, this is like hyperspace, like I just saw a science fiction movie.
I do have a question from Patricia.
Yes, I just had a question of clarification about one of the slides. You showed a summary of several studies looking at HIV shedding from cervical and vaginal secretions if people were on HAART versus not. Were those people co-infected with STDs or without STDs?
Both. I didn't really show just the STD part. So there were some that had STDs and some that didn't have STDs. I have to look at the exact. There's a bunch of papers on the bottom, and so
yes.
It was an aggregated estimate of a bunch of papers. But for men, there's a couple of famous papers where an STD was acquired and shedding occurred, and for women, we've got a couple of famous papers like that. I'm not sure if they're in that slide, but there's no doubt that in the absence of STD, so I'm going to cite now a more current paper. Cohen, I think, had something like she had a longitudinal study, and she was looking at women, and in the face of ART suppression, even when blood was suppressed, a substantial number of women, X%, had intermittent shedding in the genital secretions. And one of the issues has been, well, where is that coming from? What's the reservoir in women even when the blood's suppressed? Then beyond that Cohen paper, there's several Trichomonas papers by Kissinger, what's her first? Patty Kissinger, and others, getting back to Kim Workowski's love of Trichomonas. Kissinger has shown shedding in the face of ART, I think, during Trichomonas treatment, and there's many others like that. So it's both situations occur.
Okay, thank you very much.
Thank you.
Thank you. And our next question is from Teresa Schwartz.
Thank you. Can you hear me?
Yes.
I did have to step outside the office for a minute. I apologize if you discussed this already, but now that we're doing fourth-generation antigen testing for HIV, I wonder, isn't it time we move to the same thing for STDs? A number of STD clinics are not using DNA amplification tests for gonorrhea and chlamydia because it does cost more, but particularly for chlamydia, we may be missing up to half of the infection by culture, and I just wonder what you think about what we should do.
I mean, I'm not sure which. I mean, this gets back to like a long time ago with Genzyme and these other tests many, many years ago. I think if you don't have access to a test with veracity, it's the same as not doing a test at all. You know, there's 50% wrong direction. So no, I would embrace that if a diagnostic test is being done, you should use a diagnostic test with veracity. You know, whose sensitivity and specificity justify the test, especially in this modern era. So I hope not many clinics are using that kind of diagnostic. I hope most are using newer amplification tests. Good question. Thank you.
Since there is no commercially available rectal test for gonorrhea and chlamydia DNA, each lab has to validate their own, and I'm afraid many have not. So if you're looking for a study to do.
Kim, do you want to comment on that? That she's talking about the diagnostics of, because the FDA approval has not been obtained for diagnostics for rectal gonorrhea and chlamydia, that represents a challenge. You've talked about this before. Do you want to say something? Kim Workowski has actually talked about this quite extensively.
Yeah, no, we continues to be a barrier, and I think you have to reach out to your laboratory, to reach out to somebody in your region or to CDC who will help you do those validated tests. The other problem is that most people don't realize that Quest and LabCorp, there are the codes available for extragenital testing. And we have advertised those. We put them different places so that people will know. I think the difficulty has been even some of the reps weren't aware that you could do extragenital testing, and you just need to put a specific codes. So I think that we just need to continue to get the word out. You continue to call us. You can call the lab here at CDC, and they can help you with getting extragenital testing. The other thing Tom and I were just talking about, just to change the subject, one of the things I think we need to do a better job of to embrace with HIV is using syphilis as a sentinel event. And so in particular of what you said, in particular with the IPREX results that came out by Solomon, that is something we have to embrace. And as part of the PrEP recommendations, you know, you're recommending PrEP for high risk, you need to put syphilis in there. So people need to know, you get syphilis, you go on PrEP. And you don't specifically say that. So I think the point is we have to link the two together. And the best way to link those two together is put it in a recommendation.
I have a question for you.
Do you agree with that?
Yeah, but I have a question for you and Dawn. It's a comment. I'll make it a comment because I don't want to get you started. I don't want to stimulate you. No, but I think what I'm worried about PrEP, and we're doing a study, we're starting to get ready to do a study in the PTN about how do you get off PrEP. I have no problem getting on it. Dawn and I have talked about this extensively. Getting on it is easy. Getting off it, recommendations, how you stop it, under what. So you have syphilis, you start it, no problem. When do you stop it? Like, do you judge your own lifestyle change? I mean, I don't know how to do it, and I think that is a study we'd very much like to do to better inform stopping stuff. And if you want to comment on it, you can, but I think it's a research question, like, you know, how much we can inform it. This is Don Smith, who's present and who knows about this.
No, absolutely there needs to be research about it, and I think as it's being implemented, it's important that there be observational studies to understand how it's actually being done in the community. I think what we've taken is a very generic position that when you are no longer at the risk that indicated you needed PrEP, that it will be appropriate to stop it. So if I'm on it because I'm in an HIV discordant relationship, now my relationship is broken up and I'm partnered with an HIV negative and we don't think we need PrEP, that might be a good time to stop it.
Yeah. Yeah. Other questions?
This is the operator. At this time, I show no further questions.
Thank you.
So I think we are going to thank Mike. Please join me in doing that. But Mike is going to be available for another 45 to 50 minutes for those who want to have discussions with him. Thanks.
Thank you. Thanks.
At this time, all parties are welcome to go ahead and disconnect from today's conference. At this time, all parties are welcome to go ahead and disconnect from the call. Thank you for joining and have a great day. Thank you.
Everything is good. Always works.